So, Bismillahirrahmanirrahim. Assalamualaikum. Welcome to the 41st MENASO Education Academy Cerebrovascular Grand Round and the fifth webinar actually for this year. And for your information, last year our webinar series successfully gathered a global community over 7,500 participants. And obviously, this success is due to the esteemed lineup of 30 speakers, including both local and international renowned professors and consultants. Uh, Today, we're going to explore the complexity of cerebrovascular medicine with Dr. Amrou Saraj discussing about EVT, endovascular thrombectomy for large core infarcts, and with Dr. Syed Irteza Hussain covering the endovascular thrombectomy for medium vessel occlusion. And the case studies will be presented by myself, and my co-chair today will be to moderate the session, Dr. Pabaney. Okay, so as you can see from the agenda, so yeah, just now, and this is the speakers. Maybe I'll just introduce the speaker first on everything. So my co-chair today is actually Dr. Pabaney, and he's currently the assistant professor of Department of Neurosurgery and Neurology and Radiology at the Emory University School of Medicine and Grady Memorial Hospital Marcus Stroke and Neuroscience Center in Atlanta. He is a dual fellowship trained neurosurgeon with expertise of cerebrovascular and endovascular neurosurgery and skull-based surgery. In his clinical practice, he takes care of patients with complex intracranial pathologies, including brain and skull tumor, cerebrovascular pathology such as aneurysm, AVM, stroke, and perform general neurosurgical procedure as well. Additionally, he is actively involved in resident education in the Department of Neurosurgery and fellows training in the Division of Neuroendovascular Surgery. He is also heavily involved in the multiple research projects and clinical trials and routinely published in neurosurgery and neurointerventional journals. And our speaker today, we are very honored to have Professor Amrou Saraj. He's a professor of neurology at the Case Western Reserve University School of Medicine and George M. Humphrey II Chair in the University Hospital Neurological Institute. And he's the principal investigator of SELECT and the SELECT-2 trial. And he has numerous publications in leading journals in the field of neurology and vascular neurology, such as New England Journal of Medicine, Lancet Neurology, JAMA Neurology, and Annals of Neurology. And last for today, that we're going to also we have Dr. Syed Irteza Hussain. He's the department chair of neurology in the Neurological Institute of Cleveland, Clinical Abu Dhabi. He's American board certified neurology, vascular neurology, neurocritical care, and neuroendovascular surgery. Upon his completion in postgraduate training, he joined Michigan State University in 2009, where he helped establish the 24/7 neurointerventional surgery service and fellowship training program. He joined the Cleveland Clinic Abu Dhabi in 2016 and has been department chair since 2018. He has received multiple awards for his clinical work and service in the comprehensive strokes program at the CCAD and continues to be active clinically in the medical and endovascular management of patients with cerebrovascular disease. Okay, so I'll think we start first with my case. Wait a minute, the Pabaney is in. Okay, I start first, yeah? Oops. Okay, you can see my screen. Okay, so my task today, the case study that I'm going to share is basically, as mentioned in the agenda, so it's about large core thrombectomy, and I'm Ashraf. I'm a stroke neurologist from Faculty of Medicine, University of Kebangsaan Malaysia, from Kuala Lumpur, and I'm the current vice chairman of the Malaysia Stroke Council. Okay. So disclosure for this talk, there's none for this talk. So I'll start with the case. So this is a 59 years old gentleman, ADL independent, is non-smoker. However, he was diagnosed past 1 year with heart failure, reduced ejection fraction. The last follow-up, the ejection fraction was about 45%. And he was noted to have atrial flutter with no atrial fibrillation. He had dyslipidemia, and the following are the medications that he was on. And obviously, when you have this patient arrive to you, so the relevant medication I put here, he has no anticoagulant. So he is on antithrombotic, but this is antiplatelet. So the patient presented with right-sided body weakness and aphasia, and the blood pressure was 110, ranging to 110 to 130. And the diastolic is about 60 to 75 millimeter mercury, and the heart rate was 80 beats per minute. And he was in sinus rhythm during that time. He arrived early to another center nearby to our hospital, which is about 1 hour from onset. His So I'll just highlight over here when you have a patient. So basically, obviously, when you have a case that arrives to you, you are going not to go a bit too slow with the assessment, but this is a plus point for me where this patient is quite normotensive, but this is because of the underlying cardiomyopathy. Uh, and by right, when there is occlusion, then the blood pressure will go up a bit. And obviously, when there's a stroke with a cortical sign over here, the aphasia, so then you know that most likely this is cardioembolic in nature, and or it can be also thrombotic. But if there is atrial fibrillation, that's one thing. But in this case, it's going to be something high risk for cardioembolic because of there's a history of heart failure before. The onset is early at 1 hour, and the sugar is not hyperglycemic, as mentioned over here, in millimole per liter and also the milligram per deciliter. So that's quite fair. However, when I basically been asked to accept this case during the tele-stroke referral, so basically the fast ED score, we did fast ED score and it was 7. There's likelihood of large vessel occlusion, and obviously the knee score, NIH score was 22, and this is again supporting possibility of large vessel occlusion. And the scan at the nearby private was about 8:03 a.m. with no ICH, and it's quite fair to accept. Uh, and but this is a patient, as you can the title of the presentation. So basically, this is actually a patient that's being transferred. So the patient now having possibility of large vessel occlusion, NIH is quite severe, and this is a transfer case. You need to be very fast. As you can see over here, mentioned the door in out itself from that hospital is about 90 minutes. So arrived to our hospital at 9:30 a.m. and lies immediately with the CT scan. But I'll show you the CT scan. So this is one thing. So when you have a patient from transfer, there will be delay because of from another hospital. So this is a negative point, but you need to be very fast. You need to have a protocol. And in this case, because of these patients, within 4.5 hours, I'll show you the scan now. So this is a few called few slides, 2 slides of the scan. I'll try to show to you my tele-stroke apps. So as you can see over here, I'll just click this one. So from this slice over here, so you can see there's a dense vessel sign. And if you put your Hounsfield unit detector over here, obviously you need to be very fast and quite well versed with this. So this is significant dense vessel sign correlating with the distal ICA or proximal MCA occlusion. And when we scroll up at the ganglion level, you can see the early ischemic changes. And by this time around, it's less than 3 hours from onset. And you need to make sure that the window is correct. And this patient, you need to go to supraganglionic level. And obviously, if you practice called aspect score, So you know that this patient probably about uh, two and or even below. And the CT perfusion is failed. So I'll just go back to my slides. So that's what's assigned to suggest distal ICA, and this is the CT scan just now. This is dance versus sign. So that's likelihood of proximal occlusion. And you see from the CT perfusion, so I was asked to share about CT perfusion. So in our center, we do CT plane and then CT perfusion followed by CTA to determine the occlusion. So as you can see over here, so we have the time to pick the area over here, and this is the delay time. So before you see all this scan, by right, you need to see the CT plane. You have I have shown you the CT plane. So there is called low expects CT early ischemic changes with suspicion of large vessel occlusion, and obviously CT perfusion just try to concur with the area of occlusion. And if you know how to interpret, and which is not the platform today, and the delay time shows quite delay in the whole cerebral area. So this is most probably related to the cardiomyopathy itself. And not shocking enough, you are going to have early presentation with fast progressor. So you can see the CBV is quite low. This is a CBV, and this is CBF, translating to the mean transit time like this. So when you have such patient, and you know now, and we just had the last called trial presented recently. So this is a patient with the fast progressor, and this is the large core, predicted large core. So CT perfusion is predicting the large core. So this area might infarct as soon as possible. So we need to be very fast. And when you see sometimes because of our eye is actually interpreting the swelling as called a bit of hypodensity. However, if you then analyze it, if I don't have AI in my center, so we can use the telestroke app just now to determine the called the Hounsfield unit, whether this is concurring with the presentation. And sometimes CT perfusion can be faulty like this, but you just need the CT, the history, clinical examination, and also a good CT scan. We use 1 millimeter slice scan, and with good CTA. And whether you should lyse is my question over here. Then I'll just follow through, and maybe we can discuss later on. So this patient was lysed, as I mentioned before, because of this is within 4.5 hours. And one of the things that maybe I'll share, coming from Malaysia, which is a high middle income country, so still middle income capacity, we don't have fast access to thrombectomy. So we know that even when the patient arrived to us, so the when I activate the IR, so basically this is roughly within 10 minutes, we lyse the patient from arrival. And the CT scan, actually, we use the CT scan from the transferring hospital. So roughly this is from 2 hours, 40 minutes from onset, and the IR activated. However, it takes about 1.5 hours before the puncture to start. So this is the TSA. So actually, what happened is when you look at the CTA, I didn't show the CTA. There's basically non-opacification of the ICA from the bifurcation, so from the extracranial ICA. So when we put the catheter in, so then this is just a pseudo occlusion, and this is the AP view. So this is after the first pass. So this is lateral view. Let's play again. In this case, it was done during the office hour, and the patient was fortunate with only the first pass with the Solumbra technique. So this is the blood clot. So as you can see over here, so basically we lyse this patient as soon as possible. We'll then send the patient to the angio suite. The puncture, as mentioned just now, will take 1.5 hours, and we managed to recanalize the patient quite fast enough within 30, less than 40 minutes. So that was about 4 hours and 30 minutes from the onset. So this is an example of a patient with a large core that we managed to recanalize quite fast within the 6 hours from onset. So the discussion point that we will then have a discussion with Prof. Amrou after this. So basically, uh, what you can see, I just want to show to you after the recanalization, although it's relatively early, so you know this is a fast progressor. So the MRS after the stroke is actually 5. So and this patient was follow up at 3 months. So actually just to share with you the complication that occur after that. Basically, we managed to put this patient 90% of the time, or almost 100% of the time, when we have reperfusion patient, then it should go to the stroke care unit. So the good thing over there, then we have close monitoring. So this patient had cardiomyopathy that I have told before, had a bradycardia episodes, had a mild heart failure episodes, and aspiration pneumonia. Uh, this is expected in a large core patient. So, however, as you can see over here, after the 3 months review, patient able to ambulate with walking stick. As expected, this is a dominant lobe, so there's limited verbal component. Just to bring call into discussion later, and just some points here. So obviously, in any country, so with a large core, diagnosis need to be done as soon as possible. I think CT perfusion increases the confidence, all or none kind of things. So you already can see the core predicted final infarct, and this patient are within early window. So you need to basically just go for it. And in fact, maybe you don't need the CT perfusion at all in this subgroup. So basically, the large core, then you just proceed if they are within the early windows. And but the point is when to proceed and in which patient that you need to proceed. So CT perfusion, don't do it if it causes more delay and you don't know how to interpret it, and obviously if it's costly. In selected patient, obviously we'll discuss this after this. However, there's a huge role here where you need to have the multidisciplinary team in the stroke care unit. You need to be able to determine the etiology of the stroke after all these hard works to prevent the next stroke and the role of rehabilitation. I hope we'll discuss this afterwards. Thank you. Hi, Dr. Pabaney. I think we changed a bit the slots. You're still muted.
Yes. Can you hear me now?
Okay, yeah.
Okay,
Very
wonderful.
clear. So, yeah, I think the floor is yours. Just reintroduce again Dr. Pabaney. As I mentioned just now, basically he will be sharing the case studies about the medium and distal vessel occlusion case discussion.
Are you able to see my screen?
Yes.
Okay, wonderful. All right. Well, good morning, good evening, good afternoon to wherever you are. I'm Akil Pabaney. I'm one of the dual trained neurovascular surgeons at the Emory University School of Medicine. And it's an honor to be here amongst you all. I see we have a huge panel here that's here for the discussion. So seems like an exciting agenda, and honored to be amongst some of the very prominent neurologists and neurosurgeons here in our faculty today. So as requested, I also, just like Dr. Zaidi, have a couple of cases to discuss. I have no disclosures relevant to this talk. I do have some personal biases that I'll just address along the way, but we'll just move forward. And forgive me, my presentation is more from a neurosurgeon standpoint, so they'll be pretty brief and succinct. I really appreciate the details that Dr. Zaidi had provided for his patients. Mine will not be as detailed, but I'll definitely show you some other imaging that and with outcomes that might be of interest to most of you. So I have quick, obviously in the interest of limited time, I have a couple of I have two cases actually to share because I feel like middle and distal vessel occlusions are two different pathologies that need to be tackled separately, and I'm sure Dr. Irteza and our other faculty member will be dealing with those accordingly. Our first case is this patient is a 63-year-old male with a history of hypertension and diabetes. He was at work when he developed acute onset of right-sided weakness and word-finding difficulty. Other than hypertension, diabetes, not much of a medical history on him. Takes aspirin 81 daily and smokes occasionally. On arrival, he was awake and alert oriented times 2 to 3. He was agitated. Left arm and leg was 5 out of 5, but the right arm and leg was still weak, with significant expressive aphasia with an NIH score of 12. And his last known normal was about 2.5 hours ago because he was at work. His colleagues called the ambulance. He was transferred into a mobile stroke unit, where he got the CT scan, and then he was given TNK immediately afterwards. So I have some images and some videos to share here with you. So here is his CT scan, the mobile stroke unit, and obviously it looks a little suboptimal quality because it's in the MSU, but you can see his relatively good aspect score, maybe some changes about we gave him an aspect of 8 to 9. This is his CT angiogram, and you can see in the left Sylvan fissure, you'll see sort of a distal M2 occlusion, almost getting to M3. So we can debate about whether this qualifies as a middle versus a distal vessel occlusion. This was a CT perfusion. We use this software called Viz AI that helps us, that pops us on our phone and is very user friendly. And so you can see he's got a penumbra of 73 cc's with no actual core there, making him a pretty good candidate for mechanical thrombectomy potentially. And I think this just jumped into. This is going to rerun again. I'm sorry. So obviously, he had TNK on board, so that's an important consideration, especially in patients that we might be suspecting ICAD or have to do a stent placement. That wasn't the case here, but obviously there's some data that these patients might develop symptomatic intracranial hemorrhage at a slightly higher rate than the ones that do not get fibrinolytics. So obviously with this presentation and a highly functioning otherwise individual, we did an angiogram. This is a lateral angiogram. The arrow points to where you can see this sort of a medium-sized vessel occluded. You can see the contrast hanging up in that distal occluded vessel right about there. That's the arrow that's pointing that out. And you can see the wedge of tissue. So we use a stent retriever there. Typically, so my bias is I try to do ADAPT, which is direct aspiration first, if I could. But obviously, in more distal vessels, sometimes the aspiration catheters might not make it there. So we had to use, and obviously with the angulation of the vessels, you can see. So we were able to open this vessel up pretty nicely. That wedge of tissue is now getting perfused really nicely. And then this gentleman did pretty good. He returned to his baseline. And then a few hours, or actually the next day, he had some recurrent symptoms. So nothing on the CT perfusion, but then he had some hypoperfusion again in this left cerebral hemisphere. So we took him back for an angiogram. And you can see because of all this tortuosity in his vessels, he had developed a dissection from the first procedure. And it's a cervical ICA, as you can see with the tonsillar loop. So we put a balloon-mounted stent, and that restored the flow because that dissection was causing flow limitation. This is his MRI after everything was said and done. And you can see some areas of watershed infarcts, the limited infarct in his basal ganglia region, but mostly just some watershed territory infarction. But remarkably, he had no neurological deficits after this was done, and his 90-day outcome was excellent. This is a quick case of a 90-year-old lady. Typically, I'm not a fan of taking nonagenarians for thrombectomy, but this was fairly unusual because she was highly functional, was able to take care of herself, but she woke up with right arm and leg plegia and significant aphasia. She had a history of hypertension and AFib on Coumadin. And on exam, she was agitated. Her left arm and leg were full strength, but right arm and leg were out. And I stroke scale of 22 and significant expressive aphasia. Since this was a wake-up stroke, she did not get any fibrinolytics. On her imaging, as you can see, She's got age-appropriate atrophy. Some changes in the left hemisphere, as you can see, but I wouldn't, I don't see any significant or massive hypodensity in this area. And obviously had quick discussions with the family. So in this one, this is interesting because you can see changes both in the ACA and the MCA territory, but no core. The family wanted to give it a shot, and she was otherwise fairly active and healthy. This is her CT angiogram, and you can see two findings. She'll have an occlusion of the ACA, as you can see, as well as of the MCA right there. So when we did the angiogram, as you can see, she has got this occlusion of the distal MCA and the distal ACA. Right there, you can see the contrast hanging up. And then, as I had mentioned before, we did adapt in these cases. We did not use a stent retriever because the vessel size was reasonable. And also, I'm also very conscious about not trying to do stent retrievers at the elderly because our vessels are delicate. And then still you can see that ACA is also occluded. Right here, you can see the distal ACA vessel. Once again, a pretty sizable vessel. So again, we were able to do adapt on this as well, and eventually was able to open that. So essentially, we had a really nice sticky 3 perfusion. We were all happy with ourselves for the job. Well done. And post-procedure, obviously, the patient did not wake up, and we were concerned about it. So we got a CT scan an hour or so after her procedure, and you can see this, unfortunately, extensive subarachnoid hemorrhage that had happened post-procedurally. Although after the procedure, we'd usually do an expert CT on the table, and that was unremarkable, but this happened a couple hours later. And that begs the question is, what is it procedure related, or is it the disease, or is it the age, and so on and so forth. And so obviously, there's a bunch of questions that will be answered by our expert speakers is, in these cases, what imaging modalities are indicated? When is the CT perfusion helpful? Because there's a concern of ghost core and ultra early presenters. If there is a large vessel or medium vessel occlusion, should the patient proceed for mechanical thrombectomy? What are the risks of symptomatic ICH after mechanical thrombectomy in patients who have received fibrinolytics? And what is the natural history otherwise of middle and distal vessel occlusions, and what are the outcomes after intervention? And just for the sake of quick discussion, obviously there's a lot of debate as to what qualifies as medium vessel versus distal vessel, and some people look at the location versus some authors will look at the size of the vessel as to how big the vessel would be. But I think in this more recent paper by Dr. Mayank Goel out of Calgary, they look at two criteria, anatomical and clinical, and based off that, you can decide, or one can decide, what is the proposed or the composite definition of a middle vessel occlusion. If it's an M2, because there are some M2s that will look like M1, but there are some M2s that actually look like M3s, and then obviously the clinical presentation have to be taken into consideration. But having said all that, obviously the natural history of middle vessel occlusion is concerning, because even though they might have a small core or a small ischemia volume, they might have significant neurological deficits, and their outcomes could be poor in 40 to 60% of the cases. And as you can see here, the recanalization, their spontaneous recanalization is 70-20%, but that goes up to almost between 37 and 43% after the TPA. And in some cases, you could see some infarct growth as well. So obviously, with better devices, with better understanding of the disease, I think there is a more aggressive stance towards treating these cases with fibrinolytic if they qualify, and or mechanical thrombectomy with very reasonable outcomes. And with that, I will stop my presentation here, and I'll hand it over to the next speaker. Thank you very much, everyone.
Thank you, Dr. Pabaney. And yeah, that's very interesting. I think we can have a discussion after this. So the next speaker is Professor Amrou Saraj, and I think we are very lucky to have him today. Should have a very good discussion after his presentation. So he's going to be presenting on EVT for large core infarcts. The floor is yours.
Thank you so much. Pleasure to be again with MENASO. Thank you for providing the cases. My talk will be related to the large core, as you alluded. So as I mentioned, we will be going over the data from SELECT-2 and the data from the original 3 trials that showed thrombectomy efficacy and safety, pooled data, other data afterwards from other large core trials. Most of them are published, only Tesla remains. We'll talk about this population not being one population, but rather being heterogeneous, look at specific characteristics in terms of stroke severity and imaging and age that goes into consideration when you make your treatment decision. And then we'll look at the treatment effect and if it's different based on this heterogeneity, and see if everybody should be treated or there's still areas of grayness, so to speak. So we'll start with SELECT-2, and as you all know, SELECT-2 was a large core trial looking at the efficacy and safety of thrombectomy in these patients with aspects of 3 to 5 and core volume of 50 cc or more. And the trial randomized patients at 31 sites in North America, Europe, Australia, and New Zealand, was blinded, 90 days and 1 year assessment, as you will see, enrolled 352 patients out of 560 due to the Data and Safety Monitoring Board stopping us for early efficacy. And the primary outcome was 90-day. I will present 1 year as well. These are the trials sites, as I mentioned, in 4 continents. And this is the enrollment of SELECT-2 that started in October of 2019 and finished almost at 3 years in September of 2022, and reminding everybody that this was when COVID hit. So that's not just challenge enrolling a patient in clinical trial, but it's also a challenge of the resources and being able to come to the ED and consent, and this all goes to the great effort by the trials investigators and coordinators in all of the sites, adapting, and we did remote consenting. We did multiple methodologies to go through that, and really a great effort that you would see a trial with 2/3 of the sites enrolling 10 patients or more. This is quite rare. Most of the trials you see that there are 3 or 4 sites carry the trial and the rest trickle in some patients. So really appreciative of their work. We screened about 1,000 patients to enroll 352 patients. 178 went to thrombectomy, 174 went to medical management. We had 2 crossovers only, and we have only 4 90-day loss of follow-up, which again, fantastic in terms of acquiring those. The intention to treat is the primary analysis. These are the baseline characteristics, showing you the data on this population. As you may expect, it's a large vessel occlusion and large core, so the sickest of the sick. And you would see that the stroke severity is a little bit higher than the regular population of large vessel occlusion. If you look at the Hermes and Dawn and diffuse 3, it's in the 16, 15, 17 in no order. Very good breakdown in terms of early versus late window. Median aspects was 4. In terms of in SELECT-2, we did CT and CTP on all of the patients, would allow us to do assessment of the core volumes. The core volumes averaged about 80 cc as a median, which is really good illustration of large core. If you go back in time, Dawn, diffuse 3, and Hermes were 8, 9, and 10 cc's, again in no order. So this is 8 times the size of their medians, and a good illustration of large core. The results are no secret at this point. You have, this is the medical management, this is thrombectomy. This is not a population that, similar to the patient that you that the moderator presented earlier. This is not a population where you will see 60% MRS of 0 to 2. No, you won't. But you would see improvement as compared to medical management. The MRS of 0 was none in medical management. We had some patients with MRS of 0 and thrombectomy, and you have significant increase in MRS of 1 and 2 and 3, which is probably the most appropriate outcome in large core patients. Mortality was high on both ends, but did not increase with thrombectomy. So this was statistically significant. It increased the likelihood of improvement at least 1 point on the modified Rankin scale by 1.5. And that's what I usually tell my patients, with a number needed to treat of 5. Again, excellent number needed to treat when you put things into context with other treatments in medicine. As an example, you give aspirin to more than 2,000 patients to prevent 1 non-fatal MI, and more than 3,000 patients to prevent 1 non-fatal stroke. So very, very powerful treatment. Thrombectomy proved over and over again. In terms of MRS 0 to 2, it was tripled, 20% versus 70%. Please do not compare to small core where it's only limited ischemic changes, and you would say, well, but the EVT MRS of 0 to 2 was 60% or 50+%. That is not your competitor. Your competitor is medical management. Your question is, can I make this patient better with thrombectomy? Not, is he better than the patient who came in with a very good scan with thrombectomy or equal to them? And the number needed to treat was 7 for MRS of 0 to 2. As I mentioned, MRS of 0 to 3, or 3 specifically, I think is the most appropriate outcome, because you have somebody coming with a large vessel occlusion, very large stroke, and you are able to have them walking independently at 90 days. I think this is an excellent outcome. This was doubled with thrombectomy, and 40% of the patients achieved that. Symptomatic hemorrhage did not increase, was not high. There is a dedicated paper from SELECT-2 on symptomatic hemorrhage. Any hemorrhage was around 72% in SELECT-2, but that's not what matters. What matters, did the hemorrhage make the patient worse? Please remember that these are patients with very large strokes at baseline, and a very severe stroke. So it takes a lot to have parenchymal hematoma with at least 4 points worsening of the NIH. That's why the symptomatic hemorrhage did not increase, the mortality did not increase. There is a persistent finding in patients with large core, which is the early neurological worsening. This is probably because of cerebral edema and early reperfusion. It was higher with thrombectomy, but it did not detract from the overall benefit from thrombectomy. The trial is published in the New England Journal of Medicine. It has been a year and a few months since then, but all of the information is there for you all to go and read. No, the important aspect, and as I mentioned, a secondary outcome in SELECT-2 was the 1-year outcome. Think about it. These are very large strokes. It takes time, longer time for recovery. The question was, would thrombectomy treatment effect get nullified at 1 year, or is it maintained? Can medical management catch up with thrombectomy at 1 year, or thrombectomy continue to be better? That's the first question. The second question, can patients continue to improve at 1 year from 90 days? And the question is yes for all. Thrombectomy treatment effect was maintained at 1 year. The number needed to treat was 6. MRS 0 to 2, if you remember, was 20% at 90 days, 24% at 1 year. MRS of 0 to 3, around the same, 37, 38%. You see the shift is maintained towards better outcomes. The mortality, more patients with medical management died, which is not surprising. The important aspect here is it's 1 year, more time for the patients and their families to have the stroke, to sit with the stroke, to affect their lifestyle and livelihood. And that's where quality of life assessment is incredibly important. Do they regret their decision to receive thrombectomy, or they feel that it actually improved their quality? All the scores in terms of mobility, social score, cognitive function, and depression scores, whether higher or lower, were better with thrombectomy. So it is quality of life improving in this population. Then at the time before the publication of tension and last day, there were 3 large core trials and from Angela Aspects from China and Risky Japan from Japan, and we met and agreed to pool the data, which we did in the MAGNA large core meta-analysis, which whether with the same name or another name, will extend to include all of the 6 trials once all published. So you have more about 1,000 patients in the MAGNA large core patients, and all of the trials were positive. So it's not surprising that the pooled data is positive, better with thrombectomy, but it's more powerful when you have more than 1,000 patients. More accurate when you have more than 1,000 patients, and all of the shift MRS of 0 to 2 and MRS of 0 to 3 were better with thrombectomy as compared to medical management. Mortality was the same. Symptomatic hemorrhage did not increase. Again, a neurological worsening increased with thrombectomy. And I want to make a point here on neurological worsening and on the 1-year outcomes. A lot of times, as physicians who saw whether with TPA or TNK or thrombectomy, dramatic improvement. You give thrombolysis, you come back, the patient is way better. Or you do thrombectomy, and the next day you come and see the patient and they are almost back to normal. And those are fantastic and encouraging and great stories to tell and share in posters or tell your family. That will not be the case in patients with large core. Please do not expect the patient who's coming with 100 cc of core infarct to be running down the hallway on day 1. And I say it in this manner because I got questions from even our investigators saying, we need this encouragement. We need to go on. Stroke outcomes, I remind everybody, is at 90 days. And I just showed you that the improvement can continue till 1 year. The case that was presented by the moderator showed the MRS being 5 at discharge or following the treatment, and it was 4 at 90 days. And it may be better even at 1 year. So please give your patient opportunity to improve and time to recover. These are very large strokes. It takes time for recovery, and we need to be patient in calling palliative care and hospice and withdrawing unless there is a clear cerebral edema and herniation in midline shift. That's a different story, or unless it's the patient wishes. Overall, the complications were around 10% and did not detract from benefits. The subgroups, whether stroke severity, whether time, whether core volumes, whether aspects, whether clot location, hemisphere, or whether there is use of thrombolysis or not, all favored thrombectomy as compared to medical management. And the power here, when you have very large number of patients, you can start having stratification by certain cores, and still have a large number of patients that all favored thrombectomy. It's on the right side of the no difference line in favor of thrombectomy as compared to medical management. After this, there was the tension trial, a German European trial that used the aspects of 3 to 5 only aspects without perfusion images, and showed benefit, and it actually showed also decrease in the mortality with a shift towards a better outcome in MRS of 0 to 2 or 3, both better with thrombectomy. There is the Tesla trial, the only trial that is not published yet. The only trial that did not show statistical significance because this was a Bayesian, one of the reasons, this was a Bayesian design trial with preset posterior probability of 0.975 that they did not cross. I look forward to the publication. But the most important thing is, it's not that Tesla showed worse outcomes with thrombectomy. No, it showed overall numerically better outcomes with thrombectomy, but it did not reach statistical significance. So it's in the same direction. So 5 positive trials and 1 in the same direction that did not cross the midline. And most recently, the last trial was published in the New England Journal of Medicine, unrestricted core size, up to 7 hours, though, not to 24 hours. That showed better outcomes with thrombectomy as compared to medical management without restriction. And if you look at the last details, it was even more than 150 cc's that were positive. So in the presentation earlier, it was mentioned CT and perfusion, and should you do perfusion? I'm not going to comment on that. There is an editorial that Bruce Campbell and I wrote about the utility of perfusion images most recently in stroke, that you can look at those. But the point is, you can measure core size by CT or CTP or MRI. And the beauty that the trials used all of those. So you will be able to, when you have a patient in the emergency room, say, well, there were patients in the clinical trials that were similar to this patients, and I can, abstract the data, the outcomes into mine and make a decision. The aspects in core are known to everybody. Aspects measure the hypodensity. It's rater dependent. It's cheap, available everywhere. As for the CAT scan, perfusion is more sophisticated, but it has its flaws. It can overestimate or underestimate. It depends on the blood flow and velocity. In Select 2, there wasn't a lot of overestimation. Only 1% of the patients, only 3 patients were overestimation, but we were using other modalities. And MRI is the king, is the gold standard, but it's not easy or readily feasible in the emergency room 24/7. We actually compared all of those in Select 2 data. This is a recent publication from Select 2 in JAMA that showed benefit of thrombectomy in all of based on all of the modalities and all of the cores, as I will show you later. But again, you can put whatever you want into your practice. It doesn't seem that you need to deselect patients anymore, but it's estimates of the core size of the different modalities. This is to show you that all of these trials has different patients populations. They have different inclusion criteria. They were done in different countries. You can see differences in age. You can see differences in stroke severity, differences in time to treatment, differences in aspects and ischemic core volume when it was available, but they were all positive. So heterogeneous population, but still consistent results in all of the trials, again, except for Tesla that did not cross significance. You have strong, powerful evidence of maintained treatment benefit in different settings, different imaging modalities, different severities, different age populations with thrombectomy as compared to medical management. We're speaking to a group of attendees from even different set of patients that you would treat, but there is no reason to think that this data would not apply to your patient population and would not be effective, because it was the same in all of these settings. Again, I mentioned before that stroke severity differed between the trials. So it was the mildest in Angel aspects, the most severe in rescue Japan limit. And this should be giving you heterogeneity in stroke severity, but nonetheless, whether it was more severe strokes or less severe strokes, as you see by the stratified data in rescue Japan limit in last day Select 2 Angel aspects and tension, there was no heterogeneity based on the stroke severity. Time to treatment was different, and I think time is one of the important aspects to tackle. Was different also between the trials, and you will see that some of them were up to 12 hours. Last day was only 7 hours. But there is a good breakdown. We have most of the population apparently in the 0 to 6 hours, but you have significant number of patients up to 12 hours. We have good data, I think, up to 24 hours. When we will pull the data together, we will see the details, and there is any time signal. This is showing you the breakdown of and the number of patients beyond 6 hours in the different trials. Tesla and Select2 had the most, and beyond 12 hours, Select2 had the most, and you see some of the trials did not have beyond 12 hours. That's why I mentioned time will be an interesting question. But based on the non-pooled data, based on the individual publications, there was no heterogeneity by time. So whether your patients comes early or late, they continue to benefit from thrombectomy. Aspects as well was different between the trials. I think aspects 3 to 5 is a solved question. I think aspects of 2, there will be enough data. The question is aspect 0 and 1. Last they had patients with aspects of 0 and 1, but it was based on the MRI. We'll see when the data will be pulled what happens. There is no heterogeneity really based on the publications available, except for Rescue Japan limit that showed heterogeneity, no benefits of aspects of 3, but benefit in 4 and 5. Just please remember that Rescue Japan limit was a small trial, only 203 patients. They have a limited number of patients. That's why probably that was not beneficial. Just when you go and look at the evidence on totality, that's why I encourage you to do aspects of 3 is benefits in large core, and this is from the JAMA publication from Select2 showing benefit in aspects of 3. We did this specifically because of the data from Rescue Japan limit to make sure that it does not detract people from treating patients. As I mentioned, we dig deep in depth into the core volumes, and in Select2 we measured the core volumes in different ways, and Bruce Campbell has done a fantastic job with that. We measured the core volume on perfusion, on the CT hypodensity, and you will see interesting findings in the JAMA paper, and we measured it on MRI as well. And no matter what, and this last take came to confirm that more than 100, more than 150, there is no heterogeneity of treatment, thrombectomy treatment effect. That means that patients with thrombectomy do better than medical management. But we'll talk more about thrombectomy versus thrombectomy, and there is no difference in relation to mismatch or no mismatch in this population. Does that mean that all patients do well? Does that mean that all patients do the same? No, it doesn't. No, it doesn't. And this is the art of practicing medicine when you come to your individual patients and judge by them. I have a patient with a certain age and with a certain core volume coming at a certain time. What is the probability of them doing well? What is the probability of them improving with thrombectomy? You have no question that they do better than medical management, but is this acceptable for the patient and their families? We published this prognosticative models, heat maps from Select2 in the JAMA paper that takes core volume of 70, 100, and 150, and age and time to treatment, from imaging to treatment. And you see as the core volume increases, the probability of achieving MRS of 3, which I said the most appropriate or likely, a good outcome for large core, large vessel occlusion. You see that as the core volumes increase, this probability decreases. As the age increases, the probability decreases. As the time increases, the probability decreases. So if you have an 80 plus years old patient with 150 cc's who's coming late and being treated late after images, their probability is very, very low. And I think that's worth discussing with the families sometimes, to prognosticate, not to say, well, I'm not sure if they do better than medical management or not, I think the evidence support that they do better than medical management. Again, all of this information is in this paper that was published back in February in JAMA. So does that mean all of the patients benefit? Does that mean that there is no question mark? I don't think so. I think we still have to look at the pooled data, especially in patients with, I think 3 to 5 is sold. I think you still have to look at the aspects of 2 and 0 and 1. 0 and 1 in last year was based on MRI. A lot of people, most of the people here are doing aspects based on CT. So let us pull the data and let's see how that works. How about late window? I mentioned that time is important. Only 3 trials, actually 4 trials did up to 24 hours. There are 2 that didn't. So let's see when we pull the data, is there any heterogeneity by time, older age? I mean, most of the clinical trials stop at 80 or 85. There were patients older than that. I think this is another aspect to look at in relation to age and baseline disability. This is very important. A lot of times people come and say, are you asking me to treat the demented nursing home patient with large core with thrombectomy? No, that is not true. The trials did not enroll these patients, did not enroll patients with baseline disability. So just be careful. Not suggesting that you wouldn't treat them, but apply your judgment, because we did not enroll patients with baseline of more than 1 in SELECT-2, and in most of the trials more than 1, and you definitely don't have any patients more than baseline of 2. So in conclusion, we went through large core with different definitions and on different modalities, and we saw evidence in all of those. And in this heterogeneous population, from all of the trials, based on the time, the stroke severity, the core size, and the age, the effect was maintained and it was persistent. So no question that thrombectomy is better than medical management in this population, but we still have, to apply judgment and individualize by patients. There are still some questions in relation to very large cores, to patients with who are elderly, especially probably more than 85 or more than 80, and definitely not a lot of evidence with baseline disability. That's why I mentioned prognostication. Prognostication, it's not selection anymore. I don't think so. I don't think we have evidence at this point, stroke size wise, that there is a certain patient that wouldn't benefit if they have the inclusion criteria applied to them or included in the inclusion criteria. I think the question is how they will do, and if this is acceptable to the patient and their family. And I always acknowledge the great contribution from all of the people that supported the trial and enrolled in them. As I mentioned, this was in 4 continents, and I tried to visit all of the hospitals. Didn't go as far as Australia and New Zealand, but visited almost everybody in the United States and Canada and Europe. That's all I have to say, and happy to answer any questions. Thanks again for inviting me.
Thank you, Professor Saraj. Very nice, and yeah, we hope we have time for question and answer after this. So I think we move on to Dr. Hussain. And Dr. Hussain, as I've introduced before, the Chair of Neurology and Consultant Vascular Interventional Neurologist from Cleveland Clinic Abu Dhabi, UAE, and he's going to present about endovascular thrombectomy for medium vessel occlusion. The floor is yours, Hussain.
Thank you very much, Wan. I'd like to thank MENASO for the opportunity for me to speak and obviously to join this esteemed panel. The talks have been excellent so far. So I've been asked to talk about endovascular thrombectomy and medium vessel occlusions. Okay, so I have no disclosures. I'm following up from obviously the case study that Akil had presented, 2 excellent cases to illustrate what we're going to be talking about. And so the first thing is to define. So distal and medium vessel occlusions, or DMVO, or MEVOs, or DVOs, a lot of terminologies that are thrown out there. But basically, we're talking about vessels that are distal to the large vessels that are occluded, or the LVO. So about 25 to 40% of occlusions in acute ischemic stroke. This includes the MCA, distal M2 onwards, the anterior cerebral artery territory, posterior cerebral artery territory, the ICAs, the PICA, the SCA. The size of these vessels is smaller. Usually the vessel is considered between 2 millimeters and 0.75 millimeters. There are certain caveats. So the proximal to mid M2, especially if it's dominant, it behaves like an M1. So if you have a dominant M2, that's going to present as a large vessel occlusion with very large disabling symptoms and a significant amount of ischemic territory. So, and a lot of interventionalists actually do not consider a proximal M2 as a MEVO or a distal occlusion. And a lot of the original trials for mechanical thrombectomy did include these proximal M2s. The second caveat is isolated A1 occlusion. So Akil showed a case of a distal ACA occlusion, but sometimes we do have proximal A1 occlusions, but there's filling of the ACA territory via the ACOM. And then the third caveat would be the P1 segment of so the first proximal segment of the basilar artery. Usually when we have clot here, so this is usually in conjunction with basilar artery apex at least. And so, there's a lot of data already to suggest that these should be treated anyways. So location matters. So we have these distal cortical branches. We have the M2. Now, so as we go up to the circular sulcus and down, this is the area where we're going to start talking about distal vessels. This is actually proximal involvement of the PCA and involvement of the ACA. Now, these vessels are historically smaller, so they may range between mild stroke and moderate stroke. So your NIH stroke scale may be lower. However, lower NIH stroke scale may not always mean that there's no disability, and that's an important thing to look at. So when we look at the data overall, a lot of occlusions, as we know, are in the proximal M1, ICA terminus M1, and proximal M2 region. This area has been studied extensively already. And what we're looking at is other more distal branches. There's a nice review by Dr. Mayank Goyal's group, and which looks at the distal vessel occlusions. And when we look at this cohort, which was around about 258 patients, sorry, excuse me.
I didn't get that. Could you try?
Sorry, my Siri got activated. So distal occlusions are more common. M3s is what we're looking at, but then we can also encounter them in A2s, A2, A3 segments, so the pericallosal or callosal marginal arteries, and then obviously in the distal PCA. So these are the real areas that we're talking about. So detection, and Akil touched upon this. So we're very trained now. Most stroke systems are trained to pick up LVO. You already have a tip-off from the neurological examination. Somebody comes in with a large hemispheric stroke, aphasic, globally aphasic, hemiplegic, gaze preference. You're going to likely see that occlusion. But what if the symptoms are slightly more subtle, but there are cortical findings? That's usually a tip-off. And when we look at imaging, what has been proven to be better is multi-phase CTA, so multiple phases of CTA, where you may see actual hangout. And then also the color maps that are generated by CTP or secondary color maps from CTA in some instances. When you see these color maps that are generated, they may pop out at you and aid in the diagnosis. But I think it has to start with a high level of clinical suspicion. When you have a significant disabling deficit and there's definitely some type of cortical finding, you have to be suspicious for this. So the context of distal occlusion is important because it can occur in a variety of situations. So you have primary occlusions of IVT eligible patients. So somebody's presented within the window and they don't have an LVO, but they have a medium to distal vessel occlusion and they're eligible for TPA. You have primary occlusions in IVT ineligible patients, so they cannot get thrombolysis. or secondary occlusions arising during the thrombectomy procedure. And we'll talk about these. So overall, we have to look at the report card of thrombolysis, and historically we've used TPA, and most recently we now have TNK data. And as we know, recanalization of large vessels, M1 and ICA and basilar artery has been lower, but as the vessels got more distal, the recanalization rates were higher. So partial versus complete has been higher historically in M2s and M3s. And this actually was seen also in the Intersect database, where as we went from proximal vessels to distal vessels, the recanalization rate, the successful recanalization rate improved. So we do know that thrombolysis works as the clot gets more distal. It may be a function of clot burden, and we know that it's more effective. Okay, and so it can recanalize up to 43% of these distal occlusions of the M3, MCA, ACA, or PCA, and about 37% of M2 MCAs. And when we look at functional outcome, when we correlate this, we do know that in patients that do get thrombolysis with these distal occlusions, they have actually a better favorable outcome. Furthermore, we know that patients who get alteplase or thrombolysis and also who actually recanalize, these are the patients that actually do better. So yes, if they are eligible and they get thrombolysis, and if you achieve recanalization, these patients are going to get better. But if we then go back to the original statement that when you have a smaller vessel occlusion, maybe the territory of ischemia is smaller, and you may not have a majorly disabling deficit, but the context. So if it's somebody who is a driver for a profession, and now they have a PCA occlusion, having a field defect, they may only score 1 or 2, but that's disabling symptoms. Right. So the context is going to be important. However, somebody is elderly and has poor vision at baseline, maybe that PCA occlusion is not irrelevant. The other part to this is also the definition of outcomes. So when we talk about excellent outcomes, which is MRS 0 to 1, then that varies. And an excellent outcome in these patients can occur in about 50% when they do get thrombolyzed. But 33% of these patients were actually not functionally independent. And overall, in the same data set, there was over approximately a 9% overall mortality rate as well in these patients. So not all of these occlusions are necessarily benign. So thrombectomy for these distal occlusions. So what do we have to consider? So look at the functional impairment, look at the degree of eloquence of the area that is ischemic. There may be lower NIH, but it still is disabling. Recognize that the target vessel may be small, it may be more tortuous, and potentially fragile. And then you have to balance the benefit versus the risk, where the treatment effect may be lower. And obviously, as Akhil also pointed out, sometimes these outcomes or endovascular procedures can be hazardous, especially if you encounter a perforation. Maybe you have thrombolysis on board. So we have to keep this into account. So this is an illustrative case that we treated. This is a gentleman who presented with basically predominantly expressive aphasia, so disabling symptoms, and mild weakness. Aspects was okay. We saw a hyperdot MCA sign on the in the insula on the plain CT. CT angio did show distal occlusion. We decided to take this patient to angiography. So this is a lateral view, and you can see that there's a big defect more anteriorly, and you can see this vessel hanging out. We chose to treat this with aspiration technique, ADAPT technique, single pass. We were able to revascularize it. When we put these side by side, you can see that this distal M2 area was occluded, but there was significant area that it was perfusing. And that's why there was a significant deficit in this scenario. This patient had a very good outcome. So as far as technique, when we're looking at these distal occlusions, there are many devices, and the devices are constantly adapting. Remember, as we're going more distal, the vessels are getting smaller in size. They may be more tortuous. You need longer catheters, longer devices to access them, catheters or systems that are less traumatic. And so there are a variety of systems out there, but basically aspiration, using a retrievable stent retriever plus minus aspiration. And then there's always an option of intra-arterial thrombolysis. So these devices are evolving as we move along. Now, there are a variety of single center or multi-center registries and cohorts that have been published throughout the literature. And overall, there's a variety of approaches, variety of definitions. Stent retrievers predominantly have been used, but some also use distal aspiration. And when you pool all of this data across the board, about 971 patients, the pooled rates of successful reperfusion is 84%. Favorable outcome is 64%, right? Which is looking up to Rankin of 2. 90-day mortality is around 12% with a symptomatic ICH rate of 6%. When they compare subgroup analyses by the technique or the vascular territory, and also looking between primary and secondary distal occlusions, there's really no difference. And again, obviously, these are not randomized controlled trial data. That is still pending. But for what it's worth, from these self-reported registries, this is what we have. So we know we can open the vessels in this scenario. What about primary occlusions in IVT ineligible? So if you have a patient that's arrived outside of the window, well, if disabling symptoms with a prominent vessel occlusion, and if the center has the expertise, they may pursue or transfer to a center that can. But are all patients IVT ineligible? And that's where expanding the window beyond 4.5 hours based on multimodal imaging has been slowly increasing. And so there will be some patients that are competing for this. What about advancing frontiers in medical management? So we've talked about expanded window thrombolysis. What about the role of 2B3A inhibitors? There's a lot of literature coming out of China most recently of tirofiban and aggrostat in this scenario, where maybe there's going to be resurgence of treatment. And then intraarterial infusion of lytics. I know there's at least one protocol that I'm aware of, Rescue TNK, that is going to be explored, looking at the use of tenecteplase intraarterially to treat distal occlusions. But we do have data from registries and also from some of the trials that I mentioned, which did use dripping of lytics for distal occlusion. So clinical trials. So is there data for these distal occlusions? And multiple clinical trials are underway all over the world. They're looking at distal occlusion thrombectomy versus medical management. There's significant heterogeneity regarding target locations, time thresholds, imaging selection, and the use of thrombolysis. And likely, at the end of all of this, thrombectomy alone versus thrombolysis alone will likely not be answered by any of these trials. And there's a nice review of this in the JNIS recently addressing this. These are the trials that I'm aware of and that have been reviewed in the literature. So multiple trials. So we have DISCOUNT, we have Distal, Distals, DUSK, ESCAPE, MEVO, Frontiers AP. They're looking at a variety of devices. So looking at stent retrievers, smaller stent retrievers, looking at aspiration catheters, and then mainly looking at distal M2, though some have included proximal M2 on non-dominant M2s, minor symptoms, variable hours here, and variable inclusion-exclusion criteria. So secondary occlusions during mechanical thrombectomy for LVO. So those of us that do intervention, we do encounter these. So emboli to new territory, distal territory, or both. These are new occlusions encountered during MT, and usually when we see them occur during MT, a lot of bias is there to try and chase them, because we are looking for, we are shooting for higher reperfusion scores, because we know that the greater the scale of reperfusion, the better the outcomes. So if you have a TICI 2B, which versus a 2C versus complete reperfusion 3. So interventionalists will chase these secondary occlusions that occur during MT. Sometimes we're rewarded, but sometimes, as Dr. Akil showed earlier, sometimes it can be less forgiving. Now, that may be the natural history of the disease, there may be advanced age, there may be other factors, the presence of thrombolysis on board, but we have to pursue these with caution. So this is a patient that I treated. There's a left MCA proximal M2 occlusion, dominant, aphasic, hemiparetic. We can see the occlusion highlighted there. We treated this with a stent retriever, single pass. Now you can get caught celebrating and rejoicing at the recanalization, but that's where it's very important to look at your images in both planes. And now, lo and behold, we had thrown an embolus to the ACA territory in this scenario. So distal ACA territory. Now, given the fact that this was a de novo occlusion, we decided to chase it, used a second stent retriever, and were able to recanalize this vessel. And on this instance, we were rewarded. So the pursuit of complete reperfusion, or TICI-3, and in the interventionalist world, we tend to quote Voltaire, where perfection is the enemy of good. I remember my mentor used to mutter that every time we would be pushing the envelope in the lab. And in pursuing distal occlusions, we have to ask ourselves, the site of occlusion, is it the personalized relevance of the deficit for that patient? What was the status of this territory in baseline parenchymal assessment and angiography? What is the vessel size and tortuosity? And is there a role of lytics or antithrombotic therapy? Can you use chemical versus mechanical? I think there is a bias towards using aspiration as we get into these distal vessels, as opposed to pulling stent retrievers, though the jury is still out on that, whether one is better than the other. So what is the approach? So if within the window, administer IVTPA or TNK, assess the site of occlusion and or volume of tissue at risk, ischemic core versus penumbra, and or disabling symptoms. So you may choose to use perfusion maps or to understand it, or if the patient truly has disabling symptoms with cortical signs and you have a high index of suspicion, you may pursue it. And then considering EVT if the patient is having a disabling stroke. And then obviously, if you have access to clinical trials, and these are the patients that need to be studied and enrolled in a trial if possible. So in conclusion, the natural history of these distal occlusions isn't benign, even with medical therapy. That being said, thrombolysis works. Thrombectomy also works, but the level of evidence is weaker. Is one conclusively better than the other? We don't know that yet. Is a combined approach better than thrombolysis alone? We don't know that yet. Device design and technique is adapting. So devices are getting smaller, longer, less traumatic, and trials are underway. However, likely even after the trials, therapy will be a combination of treatment, i.e. Mechanical as well as chemical/medical. And I will stop there. Thank you very much once again for the opportunity, and I'm happy to join the panel to answer any questions.
Thank you, Dr. Hussain, for the excellent presentation. And I think we have about 7 minutes for question and answer. Dr. Akil, yeah. So I think I start first and ask maybe about the large core first to Professor Amrou Saraj. I think you mentioned most of the things that I tried to ask just now during your presentation, but maybe looking into the Q&A, Akil already answered a bit, but maybe this is the usual question among the participants. Basically, what is your advice in terms of large core? What kind of imaging selection? You mentioned just now. So whether you will still go for just CT scan, MRI, with or without CT perfusion or perfusion imaging?
Well, I mean, I think that's a good question for me to reiterate. It does not matter. We have evidence that thrombectomy is beneficial in large core. Instead of arguing, I still need CT perfusion, I should just do CT, just do whatever your practice is. I think that estimating the core size accurately would give you good prognostication? Yes, I do. I do think that looking at the aspects might not be as informative as looking at the perfusion or the MRI and seeing that the core size is 120 versus 80. But if the question is, should I treat this patient with thrombectomy or not? Are they going to do better than medical management? This is resolved. If the question is, how will they do? Would this be acceptable to the family? Prognostication, I think this is when it would be beneficial to get additional images to prognosticate. But I think selection is becoming from the past at this point. It's more about prognostication. And when you think about this from a larger scale, from systems of care, you may come to a point and say, okay, well, if I do additional images, there will be certain patients that the probability will be very low, and I might not treat, right? But on the large scale, from systems of care and you're doing unified and guidelines, doesn't matter. Is it worth it to do it? You might come to the conclusion, no, it's not.
Thank you. Just a call. Yeah, I think I love the way how you put just now. So now with all the trials, you have all the trials showing CT plane aspects or CT perfusion and so MRI based. So choose what you have and what you're comfortable with. And yeah, I think you already mentioned a bit. There will be a further analysis about the time factors, whether that's relevant. So we hope to see more about that because of personally going into that. I really think there's a bit of time issue over there. We need to recanalize. If you decided to recanalize, I think you need to do as fast as possible. Dr. Hussain, you raise your hand, but can I ask a question to you also?
Sure.
At the same time, what kind of imaging then you prefer? Because of, in medium distal occlusion, majority of the time, we know we do lots of CT scan. Will you just do CT scan and CTA as the screening, or any specific imaging that you prefer?
Yeah, so we have the automated software. We do CT and CT angio on all patients. It's dual phase. It doesn't have 3 phases. And then we get the reconstructed maps and we look at that. But it's really usually, if the exam is not fitting, then we like to go for the color maps. So we don't do immediate perfusion on every patient. If we have a high index of suspicion of cortical findings, then and the CTA, we're not picking it up on CTA, then we might push for that perfusion map. But increasingly, we've become better and better of picking it up on the dual phase CTA. But I think, again, the exam, if you have disabling symptoms which are fitting like a cortical pattern, you really have to have a high index of suspicion, go back to the imaging, and usually you'll find an occlusion that's been missed. And that's where the 3D reconstructions and the reformatted images really help with that in detecting. But I had a comment and a question for Amrou, if I may, while I have the mic. First of all, wonderful talk, really enjoyed it. A comprehensive review, and I have to agree, it's changed things even here in the UAE. We increasingly now we are not selecting on this. We've changed our protocol at Cleveland Clinic Abu Dhabi. But the question of prognostication still arises. And I wonder if, for low and middle income countries, resource stricken, we have to keep reiterating the fact that I like to call thrombectomy is an apex feeder, right? We were dependent upon the entire stroke chain of survival, both before and after. And we have to make sure that, there is rehab available. I mean, as you rightfully pointed out, patients, we're looking at the 90-day to 360-day outcome. And is that going to be financially viable? And, I don't think I necessarily have a question or critique, but I was just wondering, with your world experience, what are your thoughts for low and middle income countries and how this data can be applied in this scenario?
Yeah. Well, I mean, and that's a great question. I think, look, Brazil had done the resilient trial and showed that they can replicate. You can argue that Brazil is a second level, not a third world. But I haven't visited Cleveland Clinic Abu Dhabi. I visited Rashid's hospital and few other venues. I would say that very good setup, very good progress, excellent. You all are doing a fantastic job, and I hope this expands more and more. And I think there are a lot of initiatives that can help with that. I think, I wouldn't do something like, well, because the probability is very low in patients more than 120, we will not treat more than 120, because you might have somebody who may benefit, and you might have the circumstances. I think you can shape everything within the state of what you have and say, well, the probability is low and there is no rehab, so we may be considering things in this manner. Keep something in mind, that most of these trials do not collect data on the rehab. We don't know who gets rehab and who doesn't get rehab. And this is beyond the trial's ability. And this is one of the things that I think is next. Even with small core, you have 0 to 2 and 50%. To 60%, maybe up to 70% in 3. What happens to the 30%? Put the complications aside. I think this is a call to optimize rehab, optimize care in large core. I think you will see the next wave is the neuromodulation and neuroprotection, because a lot of patients die, a lot of patients don't do well. So this all comes in line with optimizing things. I think, again, definitely you will have to tailor things into the resources and all of that. But I don't think we should put a hard limit for any of this. And I think you all did a fantastic job adapting the most up-to-date treatments and all of that. I mean, I've been to Riyadh, to Saudi, really also impressive setup. So push the limit as far as you can.
Thank you.
Thanks for the good question and nice comments.
Do you have any question?
Looks like
may I
there's
ask
some
then?
questions in the. You want to read out these questions, if anything we should answer that people are posting?
So I'm trying to just summarize a few questions relevant to the topic today.
I've tried to answer all those questions live as we go along. But I think, Irteza, there's a specific question for you that talks about treating stroke and large vessel occlusion in pediatric age groups. And what are your thoughts about that? Is that something that you guys are doing in UAE?
So we're specifically not doing that. Previously, I had experience in the US, but it was mainly in adolescents. I do realize a lot of there's been a special interest group for stroke in pediatrics and stop stroke in pediatrics, where a lot of work has been done. But I'm not up to speed on thrombectomy. Maybe you guys in the US have guidelines or anything come forward yet. The youngest pediatrics is 16. Yeah.
For pediatrics?
For pediatrics.
There was a recent paper. I mean, this remains limited number of cases.
Yeah.
I mean, if you remember, for thrombolysis, the TIPS trial enrolled one patient and did not give them TPA.
Yeah.
the incidence is less, and the awareness is less, because you don't expect a stroke in a pediatric, so they come late. But there has been a recent JAMA in neurology, and when I say recent, like the last year, paper that is more of a review and showing that outcomes is better with thrombectomy. I think the median age was 11 or 12.
Okay.
Here we have institutional guidelines. We give TPA, thrombolysis, TNK 13 and more, but we add more diagnostic testing because, as you know, hemiplegic migraine is very common.
Yes. Yeah.
We didn't do any thrombectomy.
Yeah.
I think from a practical standpoint, I would just add that whenever somebody sees a pediatric patient with stroke, start thinking about different pathologies or etiologies, such as moya would be very important. There have been cases where people have tried to perform a thrombectomy in a moya affected vessel and have caused damage or ruptures. I think that's very important to identify those conditions before trying to be aggressive and trying to recanalize those vessels. Or some patients will have dissection or connective tissue disorder, so that's very important to know and understand those before treating those kids like adult stroke pathology.
Yeah,
absolutely.
I think there were a couple of questions for large core. I just want to make sure we attend to the questions. There is a question about the 130 cc's from the Hermes meta-analysis. Yeah, that's Bruce Campbell. But remember that the Hermes meta-analysis did not have the large core, so they stopped the benefit because they didn't have the population. In Select 2, up to 150, I mean, this becomes a little bit philosophical. There were 4 patients, more than 150, who achieved MRS of 3. And you can say, and within limited number of patients, you can say, well, this is just 4 patients, but it's 11%. I think when you come to last day, and if you look at last day, there is a very nice stratification by core, less than 150 and more than 150, and the treatment effect was maintained. So this is up to 7 hours. Again, I don't think there is an upper limit, at least up to 7 hours. But I think you start, prognosticating, and definitely 150 is less likely to do well as compared to 100, as compared to 50, as compared to 0. But you're on the right direction in the way that you're thinking. I think the other question is about the aspects being subjective and the 26 Hounsfield unit. This is a very up-to-date person. So Vignan and Bruce Campbell presented at the ESOC last week from Select 2 an analysis on the how dark is dark. You can look at an aspects and you see some degree of hypodensity, and you can look at an aspects and you see dark, shades of a gray or shades of dark, so to speak, darker. And so far, I just remind everybody that we are yet to find a treatment modifier. Core size is not a treatment modifier. Treatment modifier that you move from beneficial, non-beneficial. This hypodensity might be a treatment modifier. That's the referral to. But I think, although this is a Select 2 paper and we are waiting for the paper, I think A, you should wait for the paper, and I think B, we should validate the results in a larger setting with the pooled analysis. But again, with all of these questions, what are we looking for here? We're looking for the patients who we will not treat. And we are today in a much, much, much better situation than a few years ago when we were looking for which patients to treat. See how far the pendulum swung. It went from all the way select which patients to treat now to trying hard with the hypodensity, with the core size, with other features. to select the patients who are less likely to benefit. This is great for the patients that most of them would benefit.
I think one of the bigger arguments that somebody could pose at this point in time, although our inclusion net has significantly widened with all these large core trials coming out, and especially I think when the results such as the ENDO-LO trial will come out, then really there would be very few patients that would be excluded. But I think the biggest question that I always think about in resource scarce countries, where about 70% of your stroke burden is right now of the world, and obviously as somebody mentioned about limited resources, there has to be some kind of an exclusion criteria, because if they start treating patients that have a core of 120, 150 cc's, and we know that the benefit is less than 20%, then we're really talking about using or putting the resources on a stretch, because then the ability to treat patients who can really benefit from endovascular intervention is going to be limited. So I just want to see what the panelists think about that, because I think we just have to pick our battles, so to speak, in those situations.
I agree. I mean, I
that
think the
you
data
mentioned.
has to be applied to the context of the situation. I mean, as you and I are aware, there's some countries where there's no debate about, thrombolysis and thrombectomy, that, they want the most effective treatment and they can only pay for one. So which one are you going to do? So there are a lot of times there's scenarios like this, and where it may be that the affordability, if they're paying out of pocket, especially in some of these private healthcare systems, I think that discussion is a very relevant discussion, very relevant. And I actually, that's where the discussion, this prognostication data that Amrou shared, and I really like those color maps, kind of, granted, we may not even have that data when we're in these countries. We may be just dealing with a plain CT scan. But I think we will have to apply that type of data when people are paying out of pocket, to be quite honest. That's my view. That's my view, obviously.
Is there a direction? I mean, I think this is a great point that we don't see here. Is there a way that things work out similar to Brazil, that you would have public health support of treatments at this level?
So I think there's been some success in the region. So I think MENASO has done a lot for the region, and I think the region was behind in just simple thrombolysis. And then you have pockets of intervention, in the region in highly sophisticated hospitals and cities, but not at a district level. So a lot of times patients are being transferred, and they are paying out of pocket in a lot of these scenarios, private sector. And then it's a real question. They'll ask you, what is the likelihood of this family member going to be productive? Should I spend my money on this, or should I spend this money on the rest of the family? And those are the tough questions to answer.
It's tough.
Yeah, I think, totally agree. And I told the organizer this is actually quite a heavyweight call topics. We have both large core and also the medium vessel occlusion being discussed. And as I call neurologists or interventionists and neurosurgeons that treating strokes, I think this is called something that, as we discussed before, we have know a bit more about how to treat more patients and be more inclusive. At the same time, going to the low middle income country, we don't have the same access to high income country. I think we should have a separate discussion on that, called in totality, in terms of how we approach in the future. And I think, it's a great discussion today. Thank you, Professor Amrou, Professor Hussain, and Dr. Akil, and I think, we hope that we can gather again in the future webinars or workshops, and we will try to pursue for the best of our stroke patients in the future in our own region, inshallah. Okay, assalamu alaikum. Thank you, everyone.
Thank you so much, everybody.
Thank you. Thank you.